So this is my day job, but I also work for the Academic Health Science Network, and two of my colleagues, Jackie and Joe, are here today. And this is very much a pitch, and it's a pitch to try and support you if you're interested in using physiological measurements for patients, particularly NEWS. And we're here in the tea break, and we'll be here afterwards so we can answer any questions. And the session is basically designed to stimulate discussion about whether this would be useful, if it would be useful to you, how we support its use. And I'll start off with some brief introductory slides, and then we've got Joe, who's a local sepsis survivor, and Julian, who's a local GP, who's going to tell us a bit about using NEWS in primary care. So, in a secondary care context, in an acute trust, all sorts of people are measuring all sorts of things all of the time, and changes in any of these distress signals have clear mechanisms by which care is escalated. Just by way of context, everybody gets lots and lots of alerts saying this is really, really important, and this is the new mechanism by which we can change X, Y, and Z. Patients get bombarded with things. Healthcare professionals get bombarded with things, priorities, and some are shared between different audiences. I went to a meeting last week about healthcare innovation, and if you realised the savings in financial terms and in lives saved from all of the different presentations, nobody would ever die and healthcare would never cost anything. But realistically, not all of those gains are realisable. So this is taken from the RCP website. I don't know if Edna was a real person to begin with, but she now exists here. So she lives in a nursing home where she's lived for 2 years. The staff attentive, very, very familiar with her patterns of behaviour. And over a few days, she hadn't been feeling very well, had a nasty cough, pale, lethargic, no pain, but not eating or drinking or anything. Does this sound familiar? Do you get calls like this in your practice? We get calls like this about patients with CKD and transplant patients from relatives or carers. So what next? Urgent home visit, send an ambulance, ask the home to send an MSU, emergency slot, call back later, or something else. Any votes for urgent home visit? So myself and Joe have visited a few GP surgeries in respect of work about AKI, and the demand for home visits is extraordinary as far as I can see from having sat in clinic. So send an ambulance. So lots of different answers, and it may be that more than one answer is right, that several of these things might have happened in the real world. But she's somewhere where the nursing home has things to do obs with and somebody to do them, and the nursing home manager checks the observations. Temperature 38, systolic of 120, heart rate's nearly 100, respiratory rate's over 20, and there's a pulse oximeter, and her O2 sat to 93. So if we went back a slide, has anybody changed their opinions about what to do next? So early morning scores, you're probably very familiar with this, but there are numerous early morning scores, composites of different types of information with scores that reflect weighting, and the components vary, but the more accessible these scores are, the more they're based on physiological rather than laboratory or near patient testing. And obviously oxygen, inspired oxygen may be used in early warning scores. The Royal College of Physicians delivered a national early warning score in 2012, and in December of last year it was updated, and it has these components: respiratory rates, oxygen saturation, systolic blood pressure, pulse, level of confusion or new confusion, and temperature. New confusion is something that we always get asked about. What happens if you don't know whether it's new or not? I think if you don't know, you assume it's new. And the scoring goes from 0 to 3, depending on the abnormalities in the factors, the composites that deliver this score. So not being alert scores you 3, whichever level of severity it is, whether you're confused, responding to pain, or not responding at all. And in secondary care, there's a great deal of concern, pushback about which oxygen scales to be used. We can talk about that at the break. I'm not going to go through that now, but people do have opinions about whether chronic lung disease invalidates this kind of approach. In secondary care, this is the OBS chart used in the hospital I work, which is the Royal College of Physicians one, with coloured bars to describe the scoring and try and make the scoring easier. One of the problems in secondary care environments is the abnormalities in these parameters often don't turn into an accurate score. And that's something that I think Julian may make reference to. So this is Edna's OBS chart with red crosses, and all but the systolic blood pressure there sit in bars that aren't white. The scoring's up at the top. It doesn't really project very well because it's too small. So, does display of her OBS chart make any difference to people's perceptions? I don't think it does with one-off observations, but when you see trends, I think this display with colours actually enhances people's perception of deterioration. And her NEWS score's 9. And if you arbitrarily split NEWS scores into levels of severity, this is as high as it gets. The score can go higher, but she's already above the trigger point of 7. I've put this in very small font because this is what's attached to the NEWS score in the Royal College of Physicians. But I think what's difficult to know is whether NEWS scores mean the same in every setting. And there's a difference between these kind of physiological composites having a prognostic significance and dictating exactly what actions are to follow. And that's why later on in the afternoon we'll talk about the Wessex deterioration actions, if you like. Okay. So this is a slide I borrowed from Matin Arda-Kim, who's the national lead for sepsis, who works in Wessex. He's an acute physician who works in Winchester. And this is a comparison of a couple of cases, real-life cases from his experience. And this is Mrs. X, who I suppose might be Edna, who becomes unwell, who calls reception more than 12 hours later, and then goes through a huge number of transactions, points in the road, at which things can happen quickly, slowly, or not at all. A bit like X-rays going to radiology and being bounced back, which is something that also happens in secondary care. And the antibiotics were given the guts of 24 hours later. I can't remember all of the details of Mr. Y's biography, but Mr. Y was the husband of either a non-executive director of a trust or some other local organisation. And she felt empowered to just call an ambulance. The ambulance proceeded through all of these steps rather rapidly, and they rang the emergency department to say that Mr. Y was coming, that his NEWS score was X. And then the subsequent steps after arriving in another setting were delivered much more quickly, and he got his antibiotics in under 2 hours from the onset of his symptoms. And this really is just to emphasise the opportunities that speaking the same language may offer to accelerate time-critical steps in the management of patients. So I showed you the slide advertising FAST, the approach to strokes, a good example of something with really very tight windows for delivery of care. And a lot of the enthusiasm for NEWS is based on the importance of sepsis and the importance and impact of delays in treatment. Mrs. X was discharged after 17 days in hospital and went from being independent at home to having carers twice a day. Mr. Y went out for 3 days without any additional support. And in a world where there's a limited pot of money for social care and healthcare, this difference is enormously important. This is in survivors, obviously. So, if you worked in secondary care, anything new is held to account against these components here. In the AHSN, we're greatly interested in all of these domains of quality, but we're aware of this problem up here with quality and efficiency on sale from the vendors. But the reason that physiological scoring and NEWS in particular may offer great advantages, the scope for enhanced timely intervention, enhanced patient experience. I think we need to start thinking about functional state after acute episodes of ill health. I think this offers great opportunities for triage. If you get a call from a nursing home about Edna and her NEWS is 0 or 1, it empowers people to make different decisions from not knowing that overview of her. And I think there's definite scope for enhanced transactions between sectors and between healthcare professionals if we're all speaking the same language. So that's just summarising what I've just said. And Scotland, the West Country, Wessex and Wales are several steps ahead here and are doing both qualitative and more quantitative analyses of the impact of using NEWS scoring. And immediately after the break, we're going to show a very short video from the west of England. Hopefully it's going to work. And this is data from Scotland. And it's data from all of the health boards in Scotland. And it's really up there for two reasons. The objective here is to improve outcomes. And this is deaths from coded sepsis. But equally, there's a caveat. There are hundreds of things that contribute to this kind of change, and we're not saying that NEWS is a panacea, but it is something that offers opportunities to enhance communication and triage and discussions about how we manage patients like this.